Okay, so this is the recorded lecture for week 6. I'm actually going to start with chapter 21. I do want to remind you that when I do these lectures, I don't always lecture on every one of the slides from the PowerPoints that were posted at the beginning of the semester. So I have posted the entire PowerPoints for all the chapters. I've also posted the PowerPoints that I'm using for the lecture. And then I have also added, there is a article on there on fetal heart rate that I'm going to go over during this recording as well. So we're going to start with chapter 21. Chapter 21 talks about pre-labor complications. First being that I've listed here is the preterm labor. These are the risk factors for preterm labor. So there's 2 slides of risk factors. Now you don't have to have all these memorized, but just be aware of what some of these are, and that your patient who has any of these risk factors prenatally may be at increased risk for preterm labor. So you will want to be aware of that, and then you will want to educate your patient on what these risks could possibly mean. So here are the signs and symptoms for preterm labor, and as you read through these, uterine contractions at least every 10 minutes. So Braxton Hicks can occur as often as every 5 minutes. The pregnant patient can have menstrual-like cramps. She could have that all through pregnancy and it not be preterm labor. She could have low back pain, changes in vaginal discharge. So some of these things could be complaints that your patient presents with every time they come in for a prenatal visit. Doesn't necessarily mean that they are in preterm labor. However, because these signs can be so common in pregnancy, many nurses or even physicians will overlook these and miss that these are actual signs of preterm labor, which we want to intervene with. So we need to teach our patient the signs and symptoms of preterm labor, the risk factors that would put them at risk for preterm labor. We need to teach them about how to evaluate their contraction pattern, teach them when to report their signs and symptoms. And then we as the caregivers need to take every one of these calls seriously, even if this woman calls every week. And every week we have her come in and we determine she's not in preterm labor. So because the first time that you poo-poo one of these gals, she is truly going to be in preterm labor and might have home preterm birth, which would not be good. Now these are some strong indicators of a person who would probably go into preterm labor, and you can see a person with multiple gestation, that is a person with a twin or more, triplets or something like that. They're that's a strong predictor for them to go into preterm labor. A woman who has had bleeding issues, okay? If we are doing serial ultrasounds for some reason on this woman, and we see that her serial length is shorting, her cervical length is getting shorter every time she visits, then that is a strong predictor that she will go into preterm labor. So these are a little bit different than risk factors. These are predictors of preterm labor. Now, preterm labor is any labor that occurs between 20 and 37 weeks gestation. If it was occurring before 20 weeks, it would be a threatened abortion or an abortion, a miscarriage, okay? Usually the contractions are 4 in a 20-minute period. We sometimes even tell our ladies 4 in a 60-minute period, but as far as your exam is concerned, at least 4 in 20 minutes. Then if we're checking our cervix in the clinic, then she has greater than or equal than 80% change in her dilation. Now, if we do have a gal that's in preterm labor, of course, we want to maintain good uterine blood flow. We want to put her on the monitor, see if she's having contractions, and make sure that we have fetal well-being. these are some of the interventions that we will do for a woman in preterm labor. So we will put her on her left lateral side. So you will hear very often about positioning a pregnant patient, and we would like to have pregnant patients positioned on left lateral. So if they're on their left side, laying on their left side, their right side is up, of course, right? So their inferior vena cava is on the right side of their body. Now when a patient is laying on their back or even on the right side, they have the weight of their uterus laying on that vena cava. If they have the uterus on the vena cava, then the cardiac output is going to be affected. Therefore, blood flow to the placenta is going to be affected. Therefore, oxygen exchange in the placenta is going to be affected. So the ultimate position to be having a pregnant woman is actually left lateral. However, right lateral seems to displace the uterus enough that it's not actually resting on the vena cava. So a maternal position is intervention of IV fluids. We'll be doing some labs and, of course, some ultrasounds to kind of see what's going on. If indeed she's in preterm labor, we have all these medications that we can try. Some of these medications, if they work and if they're PO medications, she could possibly be prescribed these medications and released from the hospital and take these medications at home. Mag sulfate is not one of those. That's IV medication that she will be admitted to the hospital for that medication. Now, you can have preterm labor, or you can, and that's contractions, okay? Preterm labor is contractions, and it is a change, a dilation in her cervix. A woman can have rupture of membranes without contractions. So that's called premature rupture of membranes, if that occurs after 37 weeks. So if she's term, her water breaks, but she is not contracting, she's not dilating, she's not in labor, but her water breaks, and that does happen fairly often, then we need to, if her water breaks and she's term, then we need to induce her in some way, shape, or form. So premature rupture of membranes is when her water breaks and she is not in labor, she is not contracting, and she is 37 or more weeks. If she is less than 37 weeks, her water breaks and she's not in preterm labor, so she's not contracting, she's not dilating. That's called preterm premature rupture of membranes, and you will hear people say PPROM. So that's preterm premature rupture of membranes. So premature rupture of membranes does not mean that it happened when she was premature. Premature rupture of membranes means that the water has broke before labor, prematurely, before labor. Now, if she is indeed preterm, the patient is less than 37 weeks, then it is called preterm premature rupture of membranes. So that's nice and confusing. Now, the risk factors associated with PPROM. This is not labor. This is not preterm labor. This is just the woman who her water broke prematurely, preterm, so before 37 weeks. So hydramnios. Now, if you remember, hydramnios is too much amniotic fluid. So there is a huge weight to that. So that could cause her water to break. Multiple gestation. So she's got more than one baby in there. Mom's got a urinary tract infection. We do an amniocentesis. Remember, that's the procedure where we go in with a needle and draw off amniotic fluid for a test or something like that. If she has placenta previa or abruptoplacenta, she could be at risk for preterm premature rupture of membranes. See, I'm getting it confused already. So here's some more risk factors. So she has a trauma, maybe a car accident, maybe her boyfriend beat her in the stomach, something that causes her water to break. Let's see. She could have an infection of the amniotic fluid, which is chorioamnionitis. That would possibly cause her to have premature rupture of membranes. So what happens to the baby if she has a rupture of membranes? Now, if she's preterm and she has a rupture of membranes and she's not contracting and she's not dilating, we will try not to let her deliver. We will try to keep her pregnant as long as we can, even though her water is broke. But if she is showing no signs of infection, the baby is showing no signs of infection, and the baby's fetal heart rate tracing is looking normal, we will keep them pregnant as long as we can. But if she does have a PPROM, a premature preterm rupture of membranes, I'm sorry, I got it backwards, preterm premature rupture of membranes, then the baby is at risk for developing these things. So a respiratory distress syndrome, a sepsis. Baby could, if that water breaks prematurely, baby could be in their breech because baby's only 32 weeks and hasn't turned down yet. So a malpresentation. If that water breaks, that cord could wash through with the amniotic fluid. We could have bad fetal heart rate tracings. We could end up with a preterm birth, and we're increasing our morbidity and mortality with a PPROM. So it's a very thin line we are walking. I'm going to jump ahead now to placenta previas and abruptio placentas. If you are in the hospital or in your clinic, take care of one of these gals. It's a bleeding issue and it could be very severe and life-threatening. So this is what they are. So a placenta previa is an abnormal implantation of the placenta in the lower part of the uterus. And there's different degrees of placenta previa. So there could be a total placenta previa, a partial, a marginal, and a low-lying. So those terms relate to where that placenta is in relation to the cervix. So if she has, oh, here's your risk factors. Okay, so you guys can read through those. Let's see. I guess I don't have the definitions here. So you write these out, okay? A total placenta previa is a placenta that is completely covering the cervical os, the internal cervical os. So it's the part of the cervix that is in the uterus. So you have the external cervical os and the internal cervical os. The external is the one that you get to when you do a vag exam. The internal is in the uterus, okay? So the placenta is completely covering the cervix. She cannot have a vaginal delivery with that. She will end up probably bleeding to death before she ever dilates and pushes her baby out. Plus, her baby would be being pushed through the placenta, and that's just totally bad. It can't happen. She will end up having a C-section. A partial placenta previa is the placenta is partially covering the cervical os. So not completely covering it, but partially covering it, and same. She cannot have a vaginal delivery here. The marginal previa is the edge of the placenta is at the border of the cervix. So she probably will not have a vaginal delivery here. It is too risky that as the baby is being pushed down onto that cervix and that cervix is dilating, then that dilation is going to expose more of that placenta, and that baby's head is going to be pushing more on that placenta. So she will probably most definitely not have a vaginal delivery, even with a marginal previa. Now with a low-lying placenta, she could have a vaginal delivery. The placenta is low in the uterus. It's not touching the cervix. It's not covering it. It's just low in the uterine cavity. So she could possibly have a vaginal delivery here. This would be a physician call. Okay? So having a placenta previa is going to put this woman's going to have a bleeding issue. And here are the risk factors for developing a placenta previa. The one other thing that I would like to bring to your attention is a placenta previa can be diagnosed in early pregnancy, and then as pregnancy progresses, the placenta can migrate posteriorly and up high in the uterus, and then the placenta previa is what we call resolved. Okay, so here's your fetal prognosis. So if you're having a bleeding issue, then you're going to have a fetal issue, and she needs delivered. So non-reassuring fetal heart rate and a complete or partial previa, she is going to have a C-section, and I would argue that if she has a marginal previa, she's going to have a C-section. So just imagine that marginal previa, the edge of that placenta is touching the edge of the cervix. As that cervix dilates, then it starts exposing. As it dilates and thins, it starts exposing the placenta, and then she will start having some bleeding during labor. So when she has a placental previa, she will have bright red vaginal bleeding, and it's usually painless. So we have to do some ultrasounds and see what's going on with that placenta. We don't want to really be doing a vag exam on a gal with a placenta previa, because if we do get through the cervix and actually palpate that placenta with our hands, we could cause more bleeding. So we don't really want to be doing vag exams on gals with placenta previas. Okay, so she's going to be on electronic monitoring. We're going to watch how the baby does, and then we're going to go to delivery, whichever way that is. If the bleeding is severe enough, yes, we indeed may have to do a blood transfusion. Okay, so here are pictures of our placenta. This is a low-lying placenta. It's not touching the cervix. It's just low in the uterus. This patient could possibly, or this patient will probably have a vaginal delivery. Here is the partial previa, where the cervix is partially covering, or, I'm sorry, the placenta is partially covering the cervical opening. Now, this is just an animated picture. This looks a lot to me like a marginal previa, where the borders of each are touching. So as you can see, as that cervix would dilate and thin, it would move away, it would move out and expose more of that placenta. So she cannot have a vaginal delivery. And then here's your complete. You can see that placenta is completely covering the cervical opening, and she's just bleeding here. Okay. Now let's move on to the abruptio placenta. This is an abnormal separation or a premature separation of the placenta. She does not have to be laboring for this to happen. This can just happen. Now, some risk factors for it happening: of maternal age, increased parity, so that means increased pregnancy, or multiple pregnancies, smoking, drug abuse, a trauma, blunt force trauma to her abdomen, a severe hypertension, a hypertensive crisis for mom. So here's some other risk factors. Okay. If we do an amniocentesis and puncture the placenta, we could cause bleeding through the placenta. So that is a risk factor for an amniocentesis. So here are several other risk factors. Now there are 3 different kinds of placental abruptions. There's the marginal, central, and the complete. So the marginal is, there is a small area of the placenta that lifts away from the uterus, and blood is, she is bleeding from that part that has lifted away. The rest of the placenta is still adhered to the uterus. Now, in the central abruption, the outer edges of the placenta are still adhered to the uterus, but the center of the placenta has broken away. She's bleeding in that little pocket, and it is concealed because it is trapped within the uterine wall and the placenta. Then there's the complete abruption, where the placenta has completely disengaged from the uterus and she is bleeding. So here, ouch, here's a copy of her, or I'm sorry, here's a picture of a marginal abruption. You can see here where the majority of that placenta is adhered to the uterus like it is supposed to be, but there's a small portion that has lifted away and she's bleeding from that small portion. This is the central abruption. You can see that the outer edges of the placenta are still adhered to the uterus, and she is bleeding in that little pocket, and it is not bleeding out vaginally. It is staying concealed in that little pocket. The other problem that could occur with this is if the bleeding in that little pocket fills and fills and fills and creates pressure, then that blood can be pushed into the uterine layers and cause a lot of pain. With most of these abruptions, she's going to have some level of pain. The degree of which she's abrupting associates with the degree of pain in which she's having. And here is a picture of your complete abruption. So in an abruption, she could hemorrhage to death, even go into shock, go into DIC, and if mom is having severe problems like this, then you know baby's gonna follow with the problems. So the degree in which mom and baby have problems is related to the degree of separation. Now hopefully if she just has like a marginal abruption, our hope is that that would clot off, okay, and the pregnancy, she would stop bleeding and the pregnancy would continue. But if not, then, you know, we need to get this girl delivered, because we can have, if mom can have hemorrhage, then baby is going to have problems associated with that. So they're on continuous fetal monitoring. We're going to monitor coag studies, just like any patient, pregnant or not, that's having hemorrhage issues. So we may need to get them delivered right away if the bleeding does not stop. If she's having a complete abruption, or even if it's a central abruption and delivery is not imminent, in other words, she's not even laboring, she's not even dilating, she's not even close to dilated or close to pushing, we'll need to go straight to C-section. If she is being induced, we've got to be very careful, because if we add more contractions to an already stressed attachment issue, then we might push them over the edge. Okay, so a patient with a bleeding issue always has a risk of DIC. So we're going to do all of our clotting studies. We're going to type and cross our blood for transfusions, IV fluids, do the delivery, and stop the bleeding issue. Now, if she, if there's a terrible problem with the placenta, I think we talked about accretas last week, that could possibly be an issue as well, and she may end up with a hysterectomy, which would be really, really bad. So again, fluid volume problems. So we're going to be doing blood, and we may even be doing blood on baby. Okay. All right. So if this abruption was bad enough and we ended up having a stillbirth, then that's really bad. Okay. So with any bleeding issue, we're going to be doing vital signs, monitoring vital signs, of course assessing for shock, estimating our blood loss, monitoring our baby continuously, monitoring contractions, administering blood if we need to. We're usually going to have a Foley in a person who has a bleeding issue so that we can monitor urine output. And then deliver when necessary. Okay, so let's jump to cervical insufficiency. So cervical insufficiency was once called incompetent cervix, and I still call it incompetent cervix. I hate it when they change the names of stuff. So what that is it's a painless dilation of the cervix. So she's not having contractions. She's not feeling her cervix dilate, and it's just dilating. So this could be happening anytime throughout her pregnancy. She is totally unaware. And what happens is she comes to her regularly scheduled prenatal visit, and it's found at that time. So here's some risk factors for incompetent cervix. Okay, so you can look through those. So yes, we are definitely going to do close surveillance. We're going to do a lot of ultrasounds on these gals to keep track of their cervix. They could go into preterm labor, but we want to do something to keep her cervix from dilating. And they can give progesterone supplements, antibiotics if it's an infection reason why she's dilating, anti-inflammatories, but the hallmark treatment is a cerclage. That's a surgical procedure where they go in and they stitch the cervix closed. Now they can do this. She'll come in, she'll have her cervix stitched, she'll probably just stay overnight, one night, just so that we can monitor her post-procedure, make sure she's not having any bleeding, and make sure that she doesn't start contracting. Then she can be discharged home. Now, however many weeks she is when this is happening, hopefully she gets to 37 weeks, and usually what the physician does is then he goes in and clips the stitch. So after he clips the stitch, she probably will just go into labor. It could be immediately, or it could take a couple of days, or maybe even a week, okay? So the goal is to get her to at least 37 weeks. Now, if she has a history of cerclages like in the past, or if she is developing signs of an incompetent cervix, they can just plan to go in and do a cerclage even before she starts dilating. So like if this was a subsequent pregnancy. So if her first pregnancy she had problems with incompetent cervix, so her second pregnancy, they can just plan to go ahead and do this in the late first trimester or in the early second trimester. Now, an emergency cerclage is one that is placed when she has already started dilating and has already started to thin out. I have not actually taken care of a patient who's had an abdominal cerclage, but that's also one way that they can place a cerclage. They usually go in vaginally, okay? All right, so here we go. Guys can read through this. This is basically things I have explained. And let's move on to the next slide. So that was chapter 21. Let's go on to chapter 23. So birth-related procedures. I just want to go through these. Now, I do want to remind you that, like I had said last week, a lot of this labor stuff that I'm going over, I wasn't planning on doing this with LPN students because LPNs don't usually work in the labor area in the hospital. However, this is on ATI. Some labor questions will be on your NCLEX, and as a nurse that works in a clinic, an obstetrical clinic, you should be aware of some of these things. So this will be a good base for you guys. So we're only going to hit the highlights here of things, and then you'll just have a very basic knowledge so that if you go on to the obstetrical area in the clinic, you can educate your patient. You will know about what's going on, what will be going on with them in labor, and things like that. So an external version. So you may even be doing this in your clinic. Usually versions are done in the hospital just because when we do an external version, this is where we turn the baby. We don't go in vaginally. We do this through mom's belly, like we're moving, trying to turn the baby from a breech presentation to a cephalic presentation, head down. We usually do these in the hospital. Some places do them in the clinic, but we usually do these in the hospital because we start an IV on mom, we give her some pain medicine, we give her some tocolytics, which is the medication to keep her uterus from contracting. A tocolytic is a medication we give to stop contractions, but we can give it to keep her from contracting. And then we do the version, and then afterwards we do a non-stress test to make sure baby tolerated everything well. But anyways, we do these about 36 weeks. We can do them at 37 and 38 weeks, but the more term you get with a patient, the harder the versions are and the less successful they are. So we like to do these at 36 weeks. If we have a patient that is a breech or a transverse presentation, we will like to try to do the external version, okay? Now, an internal version is something that you won't see anywhere else but the labor room. So an internal version is when we have multiples. So we have twins or even triplets, but we have usually triplets, I think, are automatically delivered C-section. But twin gestation, the woman wants to deliver these babies vaginally. So what we do is usually baby A is head down. If baby A is not head down, there's a problem right away. So we would try to do an external version on that baby. But anyways, the first baby to be delivered is delivered vaginally. Now the second baby may be in their breech. So the physician can go in vaginally into the uterus and turn that baby head down so that she can deliver the second baby vaginally. Now we do sometimes give tocolytics after the first baby is born, just to relax the uterus so that the physician is not fighting against contractions. Now when we give a tocolytic to a woman who is 10 centimeters and contracting and delivering, it doesn't just stop the contractions dead right there, but it may space them out long enough, far enough apart, that the physician has time to get in there and turn that second baby, okay? Now let's go on to an amniotomy. So that is basically rupturing, the physician rupturing the woman's bag of waters, okay? That's an amniotomy. So we do that to stimulate labor or to induce labor. So we have a woman who's come in, she's laboring, her water is not broke, she's not making a lot of progress, but if we break her bag of water, then that may stimulate her labor to be, for her contractions to be more frequent and more intense, therefore dilating her cervix more efficiently. And I say may because that doesn't always happen that way. Or we could do that as our induction procedure. So we've got a patient that comes in, we're going to induce her, and instead of just starting Pitocin, this woman says, well, you know, I'm 2 or 3 centimeters, my baby's head is low, I would rather see if you broke my water, if I could labor and dilate on my own without the use of Pitocin. That is absolutely fine. We can try that, okay? Another reason why we would break a lady's water that is in labor is if we needed to do internal fetal monitoring or internal contraction monitoring. So you can't do those internal monitorings unless her water is broke. So if we had trouble tracing the baby with the external monitor, for whatever reason the baby was too active or the baby was malpositioned some way, we were not getting a good tracing, or if we had a very fluffy mother that made it difficult to trace the baby, or maybe we had a mother who she was doing a non-pharmacological pain management where she was up all the time, she was sitting on the birthing ball, she was doing this or that. it was very difficult to keep tracing a continuous tracing of the baby, so we might want an internal monitor on. If we're not seeing contractions very well with the external monitor, we're running Pitocin and we really need to see what we're doing with those contractions, we might want an internal monitor. Okay. So anyways, those are the big reasons why we would break a woman's water. Now, when we break the water, we definitely want to assess the color of the fluid, and when they say composition, they're, do we have meconium? Do we have thick sludge stuff in that water? Do we have green water? Do we have clear water? The biggest risk for breaking someone's water, or even someone's water breaking spontaneously, is a prolapse cord. So when the water breaks and that water rushes out, it could wash the umbilical cord out with it. You can't tuck that umbilical cord back in, okay? So that is an obstetrical emergency. So what's going to happen is, as the fluid rushes out and that umbilical cord rushes out, then the baby drops down on that cervix, and it basically occludes that cord, completely occludes that cord. There's no, you might as well put a clamp on the cord, okay? So there's no blood getting back to baby. Therefore, baby is not getting oxygen. So that's an obstetrical emergency. We go straight to the C-section, and when that happens, you will see the baby's heart rate plummet on the monitor. The nurse will do a vag exam, and she will have a handful of umbilical cord. So she will take her fingers and she will push on the head, and she will push that head back up into the uterus off of the cord. And hopefully that will let the baby's heart rate come up to normal so baby can get oxygenated, but you're still going to rush to the OR. The nurse will not remove her hand from that baby's head. So she will basically climb on the bed, and she will ride under the blankets into the OR. She will stay in there as they drape that woman in surgical drapes, as they cut into the woman's uterus, and she does not remove her hand until the physician pulls the baby out of the abdomen. So that's a bad, bad deal. All right. So here is our methods of inducing our women, so you can be educating your prenatal patients in the clinic on our induction procedures. So the first way is to do what we call cervical ripening. And our goal is to soften the cervix so that when we start Pitocin, that the cervix is more favorable to the effects of the contractions. And we use medication to do that. The medication that we use most often is called Cytotec. It is actually a tablet. It comes in a 100 milligram tablet is the smallest. They have 200 milligram tablets. I think 200 milligram tablets is the highest tablet they use. But when we do cervical ripening with a Cytotec tablet, I'm sorry, I said milligrams, it's micrograms. We use 25 micrograms. So that's a quarter of a 100 microgram tablet, okay? So we take that quarter of a tablet, we put it in vaginally in the posterior fornix, in other words, behind the cervix, and that kind of dissolves, and we can place that every 4 hours until she starts having regular contractions. And then when she starts having regular contractions, then we can start using Pitocin. Another medication that some physicians use is called Cervidil. And so that's another type of prostaglandin. It looks like a little soap on a rope. So they put that in the posterior fornix behind the cervix. They leave the little rope part hanging out vaginally. They leave that in for 12 hours. Then they pull that out and start Pitocin, start the actual induction. Stripping of membranes is something that obstetricians do in the clinic. So they do a vaginal exam, they use their fingers and they kind of rotate them against the amniotic membrane, okay? And that's what's called stripping of membranes. So typically that will happen. The woman will go home and then she'll start kind of contracting and come in the next day in labor. Now the hallmark is Pitocin. So a woman produces, the other name for Pitocin is oxytocin. A woman naturally produces oxytocin. That's what causes labor, but we can give it in Pitocin IV, and there's a really strict protocol that we use when we give Pitocin. It causes contractions, so we could cause frequent, too frequent even, contractions, and we could cause strong, too strong contractions. So if we did that, if we caused too frequent or too strong contractions, we can hurt the woman's uterus. We could rupture the woman's uterus. We could also be giving so many strong contractions that the fetus is unable to tolerate all of that, and then so we may start having fetal compromise. So Pitocin is one of the big reasons why we would like an internal uterine pressure catheter, because we really want to know exactly what we're doing with contractions. So she's definitely on continuous monitoring, uterine and fetal continuous monitoring. These gals can get up and walk around. We do have telemetry units. As long as we have a good reassuring fetal heart rate, we can let her get up and do all kinds of things. And then we will run the Pitocin. And usually the protocol starts at 2 milliunits. That's how Pitocin is given, is in milliunits. We run 2 milliunits, which is equal to 2 cc's per hour. Then we can, every 30 to 40 minutes, we can evaluate our contraction pattern. And if we are not achieving adequate contraction pattern, which is, we usually like to see a contraction pattern every 2 to 3 minutes, or less than 5 contractions in a 10-minute period, then we can increase the Pitocin every 30 to 40 minutes, another 2 milliunits or 2 cc's per hour. Also, we're assessing the contraction pattern. We're also assessing the fetal heart rate. So if we're not having an adequate fetal contraction pattern, and we want to increase the Pitocin, we need to make sure that we have a reactive fetal heart rate tracing. If we don't have a reactive fetal heart rate tracing, we cannot increase the Pitocin. As a matter of fact, if our baby is looking bad, really bad, we may even turn the Pitocin off. So that's why we've got to continuously monitor these people. Okay? So you can educate your patient on the use of Pitocin, why we have to do continuous monitoring, what are the possibilities. I definitely go over this with my patient before I ever even start the Pitocin. I let them know the risks to the woman, the risks to the baby, and this is why I'm doing fetal monitoring. This is why I'm going to be assessing them continuously, and if I need to, I may end up having to turn off the Pitocin. I tell mom I may end up having to reposition you to make baby feel better. I may have to give you extra fluid. I may have to give you oxygen. I may have to turn off the Pitocin. So I do this thorough education before I hook up the Pitocin. All right, so that is the end of that lecture. So let's go on to, now I'm going to go on to chapter 20, which is our pain management. So you can let this gal know, because they have a lot of questions. They'll be asking you in the prenatal clinic, what will be my options for pain medicine while I'm in labor. And of course, this section does not cover non-pharmacological pain management, or my slides don't. Pain management, the breathing, the walking, the massage, using pressure points, using birthing balls, using the jacuzzi tub, all these other kind of non-pharmacological pain management techniques. We are just going to go over the pharmacological ones, and we're going to do it actually kind of quickly. So they can get IV pain medicine, or they can get some sort of epidural spinal type deal. So for the IV type pain medications they can get, we have Stadol, we have Nubain, we have Demerol, and please add to this list fentanyl. I thought I did that. I'm sorry I did not. I do have a slide about fentanyl, but I just forgot to list it here. But anyway, Stadol and Nubain, we don't use them typically at CMC or even at St. Pat's. I have worked at facilities in other parts of the country that do use Stadol and Nubain. It is a physician preference, okay? So, but we just don't use it that often here. Demerol is going completely out of favor because of the adverse effects on baby. They all have adverse effects on baby, but Demerol is really bad. If you have a mom with a narc abuse issue, Demerol is the last thing you want to be giving her. And it could also, you know, cause respiratory compromise, depression in mom as well. So if you affect mom, you're going to affect baby. Anyways, so I'm not going to run through these and tell you everything that's on these slides. You can read these. So here is the slide on Stadol. You can see the maternal and the neonatal side effects. So especially if you're giving these narcotics like at 8 centimeters and she delivers 15 minutes later, your baby is definitely going to come out with respiratory depression. But if you gave a narcotic when she was 6 centimeters and she didn't have another narcotic and she didn't deliver again for another 4 hours or so, your baby probably won't have a lot of respiratory depression. But just be aware of that. If you're the one that's going to be taking care of the baby afterwards, you definitely want to know when mom's last narcotic was, and you want to be prepared that you might have to really do a lot of stimulation for this baby and possibly some sort of oxygen of some sort. So here's your Nubain, and look again. So we still have respiratory depression for our baby. Demerol, look at all that. Okay, we're doing a baby. So these are the reasons why no one wants to use Demerol anymore. Say, so I haven't given Demerol to a laboring patient for, oh my gosh, I can't even remember. It's been 10 years. It has to have been at least that long. So we're just not even using this anymore. Fentanyl is the drug that we use at CMC and St. Pat's. So we can give this every hour. It does cause a little bit of depression for baby, not terrible. And it can cause some problems for mom. So especially if it causes hypotension in mom, if you see hypotension in a pregnant woman, you're going to see a problem with baby, okay, in utero, okay? The other thing about fentanyl IV medication is the first dose might work really well. The second dose might work okay, and the third dose probably is not going to work at all. So each subsequent dose is less effective. But if you've got this girl that's sitting at 3 or 4 centimeters, you know, she's kind of dilating slowly, she really doesn't want her epidural yet because she still wants to get up and walk around and sit in the jacuzzi tub. You know, you can give fentanyl a couple of times and get her to maybe 5 or 6 centimeters where she's ready now then to have her epidural. The other thing that we can do with these medications, which we don't typically do, is we can give an analgesic potentiator. So these things potentiate your narcotic. So they make them work better, more efficient, more quickly. But they're a sedative, so they're going to make mommy sleepy and they're going to make baby sleepy. So not always a great option. Now, if we have given these narcotics to the mother and we have caused a respiratory depression in mother that's severe enough that we feel that we need to reverse the effects of that narcotic, then we can give Narcan. Now, if we have a baby who's born, you know, relatively shortly after we have given mom a narcotic, we can also give baby Narcan. But I do hear from the NICU nurses, and I think I read something in neonatal resuscitation that they're going to they're going to stop doing this for baby. They're not having as good of results with the Narcan as they would like, and they're having better responses from positive pressure ventilation than giving this medication. Okay, so there's your IV drugs. Now here is your regional anesthesia. So this is your epidural, your spinal, and we say we have listed here a combined epidural spinal. I will tell you about an intrathecal. It's not on your exam, but just so you're aware, an intrathecal is something that I've used for many years in another state, and I love intrathecals. I love them more than any of these others. The reason why I love them so much is they work really well. You can give an intrathecal 2 times during labor. The woman can get up and move around and walk around after she's had an intrathecal. The one bad thing about the intrathecal is she can only have 2 during her labor. So if you give the first one too soon in her labor, then she's going to need the second one. And if that second one wears off before she's ready to deliver, then what's she going to do? So that's kind of the reason why they're not using them really so much here in this area, is they just feel like they're worthless, because people are wanting regional anesthesia a lot earlier in their labor than we don't have a lot of people who elect not to have an epidural of some sort, and we don't have a lot of people who go through the majority of their labor without the epidural. So the intrathecal is really losing its favor. So anyways, so what we do have here is the epidural, the spinal, and the combined. So the epidural is, they put a needle into the woman's back, into the epidural space. They slide the epidural catheter through the needle, and then they pull the needle out. Okay, and then they tape the epidural catheter in place. They hook it up to the medication. It's put on a pump, and it's a continuous infusion throughout her whole labor. Then she also has the option of a patient-controlled button that she can push if she just needs a little extra. It's just like a PCA for pain control post-surgical. The patient can give themselves a little extra bolus if they're having a little more pain. Now we see the patients using these when they get close to complete. Their contractions are more frequent, their contractions are more painful, and the epidural that has been running throughout their whole labor and has been controlling their pain throughout the whole labor is just not quite enough when she gets there towards the end. Now we leave this epidural running from the time she starts pushing till she delivers the baby, and then if she ends up having an episiotomy, or if she had a laceration that needed repaired, we continue the epidural, and then after that repair is complete, then we turn it off and we pull the catheter. Okay, now she will stay numb for not several hours, for an hour or 2 after that's pulled, and hopefully after about 2 hours she has full sensation and function in her legs and can get up and ambulate and go void. Okay, because that's our ultimate goal when we get to recovery, is for the woman to get up, to be able to get up and walk and void. Okay, because an empty bladder, a full bladder, hinders the uterus from contracting, and if her uterus is not contracting, then her bleeding may increase. So there's your epidural. Now the spinal is one that we usually use for cesarean sections. So they put the needle into the spinal cord, right into the spinal fluid, they inject the medicine, and then they pull the needle out, and then they proceed with the C-section. Now the combined, let me go back to the spinal. So most of the time they inject some sort of morphine into the spinal. That's called a Duromorph spinal, and that should last this woman for 24 hours after her cesarean section. That should give her good pain control. It doesn't always, so we sometimes need to call anesthesia and say, she's having some additional pain. Can I give her something else? And anesthesia will tell us yes, we can, and tell us what to give her. But anyways, that's the spinal. Now the combined epidural spinal is usually for whatever reason, They want to give her a big spinal dose, like she's having massively strong contractions. She's rating them a 25 on a 1 to 10 scale. She's having contractions every 2 minutes. She's hardly able to sit still to have this placed. We're anticipating a very long labor or something like that. The anesthesiologist may elect to give her a spinal. So he's injecting medicine right into her spinal cord and then placing the epidural, which is in the epidural space. So usually what happens is they put the needle in the spinal cord into the spinal fluid, into the spinal fluid. They're not actually penetrating the cord, into the spinal fluid, and they're either threading the catheter then and injecting the medicine and then pulling the catheter back into the epidural space, or they're putting the needle in, injecting the medicine, and then pulling the needle back into the epidural space and then threading the catheter through. So that's your combined epidural spinal. Now these next slides are going to talk about advantages, contraindications, nursing care, and all of those kind of things. And I'm going to let you read through those yourself because they're pretty self-explanatory, but there is a few things that I do want to point out. So the epidural will last her throughout the entire labor and delivery. Okay. The disadvantages, the one thing I want to point out, or a couple things I want to point out to you, is it causes maternal hypotension. So that usually occurs within 30 minutes of placing the epidural. The maternal hypotension can be severe enough that she has signs and symptoms. Now, we need to treat her for those signs and symptoms. But if she's having signs and symptoms, and even if she's not, even if she's just having hypotension and she's not really having a lot of signs and symptoms, it could be enough to affect baby. So now we're going to have a non-reassuring baby pattern on the monitor, and now we're going to have to treat mom so that we can treat baby. Okay, so that's your biggest complication that you're going to watch for immediately after that epidural is placed. And then it could prolong labor. Okay, the other thing is it of course decreases the bladder sensation. So it says here, so you may have urinary retention. Well, this is what we do. So when a woman has an epidural, we put in an indwelling Foley catheter. Okay, because we want to keep, we don't want her to have urinary retention, to have some sort of bladder issue, okay? But more so, we do not want that bladder interfering with uterine contractions, and a full bladder could, okay? So we just put in a indwelling Foley catheter, and then when they start pushing, we pull the catheter out, okay? This is funny. I like to say this. So here's your contraindications for an epidural. Patient refusal, right? So if your patient doesn't want an epidural, don't give it to her, okay? Easier than that. Now the other thing with an epidural is your anesthesiologist will not place an epidural if she has some sort of coag problem. Now they want to know what her platelet count is before they place the epidural, and depending on your anesthesiologist, they all have different ranges in which they're willing to work with. Some anesthesiologists will not place an epidural if her platelet count is 100 or below. Now, if a woman's platelet count is low, you know, we're going to be concerned in an obstetrical point of view. But 100 is low, but it's not terribly low. So I'm really unhappy when my anesthesiologist won't do it at 100. But when she gets between 50 and 70, yeah, like I'm saying, she cannot have an epidural, and they definitely will not be placing one. Some anesthesiologists will place them if they're about 100, but then there's a lot that won't. So it's just whatever that anesthesia person has decided for himself. The one thing I want to point out here about preparation is, of course, we're going to have them on continuous fetal monitoring. We're going to be watching mom's blood pressure and the fetal heart rate, because I've already talked about that. The one thing we're going to also do is we're going to give mom a fluid bolus right before he places that epidural. It doesn't matter if your woman's been there for several hours and she's had 2 or 3 liters of fluid over those several hours. We want that fluid bolus right before he places that epidural, because we're wanting to prevent the hypotension after he places it. Now, when you get your patient ready for an epidural placement, she is either going to be dangling on the bedside, and her chin is going to be tucked to her chest, and she's going to kind of be rounding over her belly so that the low part of her back is rounded like a mad cat. What that does is it opens up those vertebrae so that the anesthesiologist can get through those spaces easily. The other way, and this is not as common, is the woman is laying on her side. It doesn't really matter which side. She's laying on her side, kind of in the fetal position, all kind of curled around her belly for the same reason, to open up the spinal, to open up the vertebrae places. Now, here's your nursing interventions. As I said before, you can read through those. Recovery from anesthesia, or from the epidural, you can read through those. Here I talked about the opioid analgesia, or the Duramorph spinal. This is the one that they place that gives her pain control for 24 hours. This is the one they use after the cesarean section. Okay, so you can read through about the spinal. Contraindications, patient refusal, that's so funny. Same sort of preparation for the woman getting the spinal. Read through those interventions. Recovery from a spinal. So they are on, so when they get the spinal for C-section, they kind of are on bed rest for 6 to 12 hours. They do still have the indwelling Foley, but around 12 hours we'll be taking the Foley out, and sometimes even 24 hours, because if she had her C-section in the morning, her 12 hours is now at 9 o'clock at night. Who wants to be pulling the Foley out at 9 o'clock at night? So now she has to get up in the middle of the night to go to the bathroom after she's had a C-section. So a lot of times we'll wait to pull that Foley in the morning. It's just a clinical judgment, no big deal. Here's information about your combined. Now, a pudendal block, and unfortunately I forgot to put the slide in here, but go look in your book at a pudendal block. So there's a pudendal nerve in the vagina that this is where they're putting the local anesthesia, local anesthetic, okay? So it's a pudendal block. So this is used when your patient gets to the second stage, when she starts pushing, and you know, even if she has an epidural, that doesn't always get the perineum, okay? So, but mostly with women who have not had an epidural, and she's pushing, and that pressure and that baby's head down there, and the pain is so bad that this woman is really having a hard time pushing effectively. So the physician may do a pudendal block with lidocaine, local anesthesia. They go in vaginally. And then the other reason why they may do this is because of an extensive repair. Now, usually when they do an episiotomy or a laceration repair, it's local lidocaine anesthesia right into the labial tissues or the perineum. It doesn't actually penetrate into the pudendal nerve, okay? So there's kind of a little bit of a difference there with the episiotomy repair. But if the episiotomy repair is extensive enough, they may end up doing a pudendal block, okay? So, and actually, they don't really do these that often. I'm trying to remember the last time I was the nurse when they did a pudendal block. So it's kind of rare that they do these. So when they do the episiotomy repair, it's right into the tissue, right at the episiotomy site, okay? So anyways, here's some advantages, here's some disadvantages. So they may possibly injure something, the physician may injure something doing that pudendal block. Okay, so let's move on to, okay, so here's a few more local anesthetic complications. Okay, I want to move on to, some more epidural side effects. So you guys can read through these. I wanted to move on to general anesthesia real quick. So when we use general anesthesia, of course, that's only for the cesarean births, and we only do those when absolutely needed. So a stat C-section for some sort of emergency, either with mom or baby, and even with those, you know, is the emergency so critical that we can't get the spinal in real quick. So when anesthesia does a spinal, you know, it could take, you know, if they're really quick, it could take just a couple of minutes to do that. Do we have time to do a spinal? If not, then we go to excuse me, general anesthesia. Okay, so here are the reasons why, you know, we want to make sure we absolutely have to do a general anesthesia. Is because it also causes fetal compromise. So if you have a baby that's already at risk or already having problems, and then you do anesthesia, you are just going to increase, possibly increase your problems. But if you have to do general anesthesia, then you have to do it. We will deal with the baby. Okay, so for mom, you know, you've got the side effects for anybody who has general anesthesia for any surgical reason. They do have a risk for greater hemorrhage after delivery, and of course you have vomiting side effects or risks, aspiration risks, and maternal amnesia. Well, yeah. So general anesthesia only if we absolutely have to do it. And there have been a few times where we could not get a good enough spinal. For some reason, we weren't necessarily going for a stat C-section. We were maybe planning a repeat C-section or a primary C-section because of macrosomia or because of breech presentation. And for some reason, when they were doing the spinal, they could not get her anesthetized from the spinal. They could not get her numb for whatever reason, okay? Or maybe they couldn't even get the spinal. That's pretty rare, but there I have been the nurse on occasions where we've had to put a woman to sleep because we could not get the spinal to work. So that's another reason why we would do a spinal. All right, now let's go on. Let me check my time here real quick. Okay, so now I want to go on to chapter 18, and I've also included in Moodle an article. Oh my gosh. So I think I closed the article. So I'm sorry. Let you guys know. Let me fumble around here. Let me get this article pulled up real quick. Oh, here we are. So I want to have this ready when I start going over this article. Okay, so here's this article, but we'll go over it. Okay, so let's start with let's go back, let's now move on to chapter 18. Whoa, let's get at the beginning. Intrapartum nursing assessment. So here's just a few things I'm going to go over with in intrapartum nursing assessment. So the one thing I want to talk about is assessing fetal position and presentation. So you could be doing this in the clinic prenatally at 32 weeks or 36 weeks, or in the hospital we do this. So we're trying to assess which way the baby is in there. So we inspect the woman's abdomen, you know, a visual look, and then we palpate the woman's abdomen, and that palpation of the woman's abdomen is called Leopold's maneuver, and we'll go over that. So the other way we can check fetal presentation and position is doing a vag exam. So when we do a vag exam, what are we feeling in the pelvis? Another way we can check for fetal position is an ultrasound. You've done your inspection, you've done your palpation, you've done your vag exam, and you're still unsure of whether this baby is head down, transverse, breech. So you bring in the ultrasound and you just look and see. You can get an idea of fetal position by where you're auscultating the fetal heart rate. So if you're auscultating the fetal heart rate low in her abdomen, then more likely than not, baby is head down. If you're auscultating the fetal heart rate way high in her belly, like up above her umbilicus, then you probably got a breech baby or a transverse baby. So especially if you've got a transverse baby, you can look at that woman and almost see that baby laying in there crooked, okay? Because it really distorts the shape of her abdomen. Anyways, so let's move on to Leopold's maneuver. There are 4 maneuvers in Leopold's maneuver, and I wish I was able to be in front of you showing you this, because it's a little hard to describe this, but I do have visual slides. So let's just go through the slides. We've got 4 maneuvers to go over here. So When the woman is laying on her back, okay, you are standing at her side and you are facing her face when you're doing this first maneuver. Okay, so then you put your hands on the top of her fundus, on the top of her uterus, and you are feeling, you're pushing in and you're feeling, you're pushing in with your fingers and you're trying to feel what you've got up there in the top of her belly. So is it really soft and mushy like a butt, or is it really hard and firm like a head? Okay, so you do that maneuver, okay, and you're still standing facing her at her side, and now you're taking your hands one on either side of her abdomen, and you're just kind of feeling, do you have bumpy nodule feeling here on the one side, and that would be knees, elbows, hands, feet, or are you just feeling a smooth, continuous feeling on the side of her abdomen, and that would probably be her back. Now, when I feel that back, I'm just telling you that that's where I'm going to put the ultrasound, the Doppler or the fetal heart rate ultrasound that goes to the monitor. That's where I'm going to put that to detect my fetal heart rate, is over the fetal back. Okay? Now, your third maneuver is you're still kind of standing at her side, and you're still kind of facing her, but I'm turned now where I'm facing her belly a little more, because what I'm doing is I'm kind of taking my hand, so this person's got their right hand in the picture there, and I'm feeling her lower belly, and sometimes I have my hand on top of her belly to kind of push that, whatever is in my right hand, kind of push that down a little bit, and I'm trying to hold that still so that I'm not moving up and down, but I'm trying to feel, do I have a hard, firm head down there? Okay. Now, with the fourth maneuver, I'm actually turning so that my back is to her face, and I'm taking my fingers and I'm kind of feeling her lower abdomen. I'm trying to feel for that head again. Okay, so here's 4 ways that we're feeling her belly to try to determine what position this baby is. Now, this will also kind of tell this check right here will almost kind of tell me if my baby is facing back or facing front. Okay. All right, so that's determining fetal position. Now, I threw this slide in here because I forgot to throw this slide in last week. So this is just telling you about the stages of labor. I don't need you to memorize, how many hours it is if she's a primip or a multip. I don't need you to memorize the contractions or anything like that, but I just kind of want you to have an awareness about the stages of labor, and this way you'll be able to kind of educate your patient a little bit. So there is 4 stages of labor. Now, you see 2 stages on here. The first 2 stages of labor are actually the labor and her dilating and the delivery of the baby. That's first stage and second stage. Okay. So the first stage is her actual labor. The first stage is when she's dilating from 0 to 10 centimeters. Now, the first stage is divided into 3 stages, and you can just imagine that these 3 stages or phases have to do with the latent phase, is the early part of labor. So, she's only 0 to 4 centimeters. She's not contracting as frequently, 5 to 7 minutes. The contractions aren't lasting as long, and they're not as strong, okay, in the first stage of labor. But when she gets to that active phase of labor, that's when she's doing most of her dilating, and that's 4 to 8 centimeters. And that's when she's contracting every 2 to 3 minutes, and they're at least 60 seconds long, and they're strong contractions. This active phase is when she's probably going to want some pain medicine, okay? And now the transition phase, you will hear that that terminology. The transition phase is when she's 8 to 10 centimeters. She's getting very close to delivering this baby. You want to get set up. You want to get everybody on board. You want to be prepared. She's contracting about every 1 to 2 minutes. They're 90 seconds long. They're very strong. She still may have her epidural or whatever at this stage. Okay. or she may just be getting it. Maybe she's worked and she's done non-pharmacological pain interventions on her own with her coach all the way through the first two phases of her labor, and now she's at transition. And I'm telling you, when a woman gets to transition, if she doesn't have any pain medicine, she's probably going to get it here, because emotionally she's getting freaked out. She doesn't understand why she's getting freaked out. She's getting anxious. She may be hyperventilating. She may be shaking, and so this is transition, okay? Now, second stage of labor is from the time that she's complete and starts pushing till she delivers her baby. Now, that could be upwards to 3 hours, especially if this is the first labor and pregnancy and delivery she's ever had. A first-time mom could push upwards to 3 hours. A mall tip, someone who's had more than one baby, they could push their baby out in 2 pushes. It could be 5 minutes. It could be an hour. You don't know. So you just need to be prepared. So that's your first and second stage of labor. Now, the third and fourth stage of labor is, the third stage is she's already delivered the baby. Now we're waiting, and she's delivering the placenta. So from the time she has delivered the baby, so she's delivered the baby, and now this is the time it takes her to deliver the placenta. That could take 5 minutes, or that could take upwards to 30 minutes. But we really don't want it to be taking any longer than 30 minutes because this woman is bleeding, okay? She's not like normally, she's not like hemorrhaging or anything, but we don't want her to be keeping that placenta in there very long, because now that cervix is going to start, it was completely dilated for the baby. Now the cervix is going to start closing at some point, and we don't want that cervix to close down and then not be able to deliver the placenta. Plus, your physician is not going to be wanting to sit there and wait 30 minutes for this placenta to come. So it's the time that the baby has been delivered till it takes for the placenta to be delivered. That's the third stage. The fourth stage is from the time the placenta has delivered until her complete recovery from delivery, and that could be upwards to 4 hours. So what decides how long that is? Stabilization. So her vitals are stable. Her bleeding is stable. She's got full sensation after we removed that epidural. She's got full sensation and control of her legs. She can ambulate and she can void. Okay? So whenever that occurs, up to 4 hours, usually. Usually definitely by 4 hours. So if she's had an epidural and we've turned it off, it might take like 2 hours. It might take a whole 2 hours for her to get good sensation back in her legs. But we want to get her up and get her to void as soon as we can, because a full bladder will not allow the uterus to contract. Therefore, she might start having bleeding issues. Now, if you're in a hospital like Community Medical Center, as soon as she's recovered, you're going to transfer her from that labor room over to the postpartum unit. It's a different area, so that now you can put another labor in that labor room. So we definitely want her to be recovered before we send her to mom and babe to postpartum, because now the nurse that's taking this patient over there on postpartum, she might have 2 or 3 other postpartum mom and babes. So she cannot be checking on this woman every 15 minutes like you did throughout her recovery. So we want her to be stable before we take her to mom and babe. All right, so this kind of seems like it's in a bad place. Vag exams. I'm just telling you about vag exams real quick here. So when we do vag exams, we're looking for several things. One, we're looking for cervical effacement. How thin is her cervix getting? We want her to be completely thin at delivery, so 100% effaced. It's a subjective assessment. So you basically have to know how thick she was before how thick her cervix was before. So it's kind of subjective. So you're just kind of guessing. As she progresses in labor, so that thickness is going to go from 0%, so fully thick, to 100% fully thin. So it's really a subjective assessment. We're going to check for dilation, cervical dilation. So she's completely closed, so she's 0 dilated, to completely dilated, which is 10 centimeters. Now that's it's a little less subjective than effacement. However, you can have two practitioners go in and check her, not simultaneously, one right after the other. One person can say she's 3 centimeters, the other person can say she's 4, but pretty much we're all pretty similar in our dilation exam. And then you're going to check fetal station. Remember, fetal station is where that presenting part is in relation to her ischial spines. So she's either centimeters above or centimeters below. We use our fingers to determine how many centimeters that is. If she's above the ischial spine, she's minus 1, 2, or 3 station. If she's below, she's plus 1, 2, or 3 station, whatever that is. And then we're trying to determine what presenting part is there and which way that presenting part is facing. And here's just a little review. I think I showed this to you last week. About the ischial spines. Ischial spines being 0 station. Anything above is minus 1, 2, or 3 centimeters. Anything below is plus 1, 2, or 3 centimeters. Okay, I'm going to really quickly talk about. So this is talking about the frequency of assessment and documentation of the fetal heart rate. And I'm actually going to pause here real quick. Pause. Okay, so we're going to be talking about assessment and documentation of the fetal heart rate. So there's 2 different ways you can assess your fetal heart rate. One is by Doppler method, and you will probably be getting very efficient at this in the clinic. The other is the electronic fetal monitor. So auscultation by Doppler, AWON, the Association of Women's Health, Obstetric, and Neonatal Nurses, gives us a standard at which we need to be doing this. So this is a standard of care. This is evidence-based best practice. So if we're doing a Doppler to assess our fetal heart rate, this is what A1 tells us to do. So in our low-risk women being women without medical or obstetrical complications and fetuses without complications, we can assess this woman in labor, in her first stage of labor, every 30 minutes. So when we're doing Doppler, we are assessing and documenting every 30 minutes in the first stage of labor. In the second stage of labor, we are assessing and documenting every 15 minutes. If the woman is high risk, we're assessing, auscultating, and documenting a high risk woman every 15 minutes in the first stage of labor and every 5 minutes in the second stage of labor. But I will say to you, if you have a high risk woman, you will not be doing Doppler assessments. You will have her on a continuous fetal monitor. Okay, so if you're doing Doppler, you're assessing and documenting according to these time frames. If you have her on an electronic fetal monitor, they're basically the same. When you have her on an electronic fetal monitor, you can be doing intermittent monitoring, or you could be doing continuous monitoring. So if you're doing intermittent monitoring, you're almost doing Doppler monitoring. You're just putting this woman on the monitor for a short period of time, and then you're taking her off the monitor, and then she's going and sitting in the jacuzzi tub or walking or whatever she's doing. Okay, so it's almost like a Doppler, except she's on the monitor and you're actually having recorded tracing of this heart rate. With the Doppler, most Dopplers have a digital read of the fetal heart rate. So you will be recording that. But some Dopplers don't have a digital read. They just have the sound, and the nurse is actually counting what the fetal heart rate is. So anyways, if she's on the fetal monitor, then she has a electronic tracing of the heart rate. So frequency is basically the same. For the low-risk woman, it's every 30 minutes for the first stage, every 15 minutes for the second stage. If she's high risk, it's every 15 for the first stage and every 5 for the second stage. That's the same as the Doppler. Now let me tell you about documentation. So when a woman is on a fetal monitor, okay, especially if she's on a continuous fetal monitoring, documentation does not need to occur every time you do an assessment. So we have to, according to AWHONN, we have to assess at these frequencies listed here. So that means we have to evaluate the fetal heart rate, we have to evaluate the contraction pattern, we have to evaluate the maternal vital signs and maternal status. We have to do that according to these frequencies. So if we do it to these frequencies, well, then how often do we have to document? Okay, so AWHONN says that if you're assessing your woman every 30 minutes, and every 30 minutes your assessment is the same, you only really need to document once an hour. So like at 8 o'clock, I assessed my woman and my baby, and I got this assessment, and I've documented it in my notes. And then, so that was at 8 a.m. At 8:30, I assessed my mom and my baby, and it's the same. I don't have to document that. But at 9 o'clock, I will do my 30-minute assessment, and I have to document. So my documentation is happening every hour, even though my assessments are only happening every 30 minutes. And that's because my assessment is the same as the previous assessment. If my assessment is different in any way, shape, or form, my fetal heart rate is different, my contraction pattern is different, my mom's vital signs are different, maybe I started Pitocin, maybe I had to give oxygen, maybe I had to start IV fluids. If something was different, or if I did an intervention, then I have to document. Okay, do you understand that? I wish I could see you. So for my low-risk woman, if I'm assessing every 30 minutes and my assessment is the same from 8 a.m. to 8:30, I don't have to document. But at 9 o'clock, when I assess again at 30 minutes, I need to document. But I tell you what I'm doing. In my documentation, most computer systems have a button that says assessment unchanged. So every 30 minutes, I like to say that. Assessment unchanged. I don't want anybody to question the fact that I didn't do my assessments, but I don't want to have to sit there and document every 30 minutes if I don't need to. Okay, so I've got a lot to do as a nurse. I don't want to have to be documenting every 30 minutes. Now look, in the second stage, this woman is pushing. I don't want to have to document every 15 minutes. Okay, because I've got a lot to do. There's a lot going on in the second stage when she's pushing. But if something is different every 15 minutes, yes, I do have to document. But if something's not different every 15 minutes, then I'm going to document every 30, okay? So that gives me a break from constantly having to be at the computer. Now I can constantly be at my patient's bedside, okay? But look, if she's high risk, look how often I'm doing my assessments at high risk. In the first stage of labor, I'm doing my assessments every 15 minutes, okay? So I don't want to have to document every 15 minutes if everything is stable and everything is the same. So I'm going to do my documentation at every 30 minutes or every 60 minutes. Now that's going to depend on my hospital policy. What does my hospital policy say I have to document? Do they want me to document every 30 minutes, or do they want me to document every 60 minutes? If my assessment is unchanged, I'm not going to document every 15 minutes. I'm just going to say assessment unchanged, assessment unchanged, assessment unchanged, and then document when I'm required. It's called a summary documentation, okay? Yeah, so especially like in high risk, a high risk mom, when she's pushing, I need to be assessing every 5 minutes. But I don't want to be documenting every 5 minutes because like I have got a lot to do, and every 5 minutes to have to leave my patient's side to go to the computer, which is right at her bedside, but still, I'm focusing on my computer. I'm not focusing on my patient. I don't want to be doing that every 5 minutes. I want to be at her bedside. I want to be taking care of her. I want to be helping her, okay? So AWHONN has said we can do these summary documentations if our assessment has been unchanged. Now, I'm going to reiterate, if our assessment is changed, you have to document, okay? So we're going to be documenting fetal heart rate, contraction pattern, maternal vital signs, and maternal interventions. And then the last thing we're going to be documenting is this 3-tier fetal heart rate interpretation system. Okay, The one thing I don't like about this system is it's, I've already documented my fetal heart rate tracing. Why do you need me to categorize it? You can already see from my documentation what category my fetal heart rate is in. But no, A1 says we want you to say what the category is. Okay, so we will go over that in a minute. Okay, so so those are our documentation and assessment frequencies. We're documenting fetal heart rate assessments, and then we're going to document uterine contractions. When we document uterine contractions, we're documenting the frequency, duration, and intensity of the contraction, and we're documenting our uterine resting tone. That is how our uterus feels when she's not contracting. So we do need to document that as well. Okay? Now let me just show you what a fetal heart rate strip looks like and kind of explain it to you. So this top portion up here, is the portion in which the fetal heart rate traces. Okay, this is what a tracing can look like. Okay, so you see these numbers, 30, 60, 90, 120, 150, 180. Those are fetal heart rates. Those are the rates. When that line is tracing across one of those lines, that's what the rate is. And you can see, if I drew a line between this squiggly that's going across here, my line in the middle of this squiggly would be landing on 150. So that's the baby's heart rate, 150. Okay? When we document baby's fetal heart rate, so if that fetal heart rate would be in the middle of this section, okay, I don't say it's 142 or 143. I document in 5 beat increments. So it's 120 or 125 or 130 or 135. So you see 120 here? This next line that's not marked with a number, that's 130. So there's 10 beats of fetal heart rate between these two lines. The next line is 140. It's not marked, but that's what the next line is because it's 10 beats. 10 more beats gets me at 150, and you guys can catch on, okay? So that's the way the fetal heart rate traces across there. Down below here is our uterine contraction tracing, okay? Uterine contractions look like these big hills. That's a uterine contraction. This right here, this straight line across, that's a resting uterine tone, okay? It doesn't always, when it's resting, it's not always 0. There is still tone in a muscle, even though it's not contracting, okay? We want that to be soft, and don't disregard these numbers right here, right now. We're not going to talk about those at all. These numbers right here, 0, 25, 50, 75, those are millimeters of mercury measurements, pressure, okay? So we want our uterine resting tone. Each one of these blocks is 5 millimeters of mercury. So we start at 0, 5, 10, 15, 20, 25, okay? We want our woman's resting tone to measure below 25. So anywhere here. Now, just like a cardiac monitor, we want to actually touch this woman's belly and make sure it does feel soft, even though it's measuring soft. Okay, we don't want to totally go by the monitor to say our uterus is soft. Okay, so now that we've kind of reviewed how you read these strips, well, let's just review how you count contractions. So when you count a contraction, you count from the beginning of a contraction to the beginning of a contraction. This will determine your frequency. So these dark lines that you see, these vertical dark lines that you see running across here, that's 1 minute worth of time. Okay? 1 minute of time is passing as this paper is feeding through the machine from one dark line to one dark line. So these little blocks in between the dark lines are 10 seconds. So you can count those and see that there is indeed 10 seconds, 10 seconds, 10 seconds. Now we have a minute. Okay? So when we start here at this first contraction, then you can count 10, 20, 30, 40, 50, 60. Here's your minute. Or you can just kind of visualize where it is in the next block. So we count 1 minute, 2 minute, 3 minutes. So from the beginning of this first contraction to the beginning of the second contraction is 3 minutes. So let's count the next one. Okay? 1, 2, and a few. So three minutes would have been right here. So she's 2 minutes and what is that, 20 seconds or 10 seconds? Okay? So I would feel comfortable saying that this woman is contracting about every 3 minutes. I'm not going to say every 2 minutes and 40 seconds. I'm going to say 2 to 3 minutes or every 3 minutes. Okay? Now we're going to so that's our frequency. Now we're going to say how long are these contractions lasting? What's the duration? From the time the contraction starts, we're going to count 10 seconds, 20 seconds, 30, 40, 50, 60. So her contractions are lasting about 60 seconds. So she's contracting every 3 minutes for about 60 seconds each. Okay? When we look at the intensity, and I'm just going to tell you, this is an external monitor. When we look at what the peak of this contraction measures on the paper, it's 45 to 50. An external monitor is a very poor indicator of the actual intensity of the contraction because it's on the outside of the body. So we don't use this number to document how strong these contractions are. Okay? If we had an internal monitor, the little rubber catheter that we put in her uterus, that one will tell us exactly how intense these contractions are. But we're not going to talk about that, okay? So when I'm going to document how strong her contractions are, I'm going to say whether they're mild, moderate, or strong. And I determine that by feeling her belly when she's having a contraction. So if you push on your nose, that's mild. If you push on your chin, that's moderate. If you push on your forehead, that's strong. So when you push on her belly, does it feel like your nose? That's mild. When you push on her belly, does it feel like your chin? That's moderate. And does it feel like your forehead? That's strong. Okay? So those are the things we're going to document. Now, let's talk some particulars about the fetal heart rate. So now I'm going to pull up that article. Okay? So, unfortunately, I'm going to have to scroll here. So I'm going to scroll down to where we talk about the fetal heart rate. So there's a lot of things we look at when we look at the fetal heart rate. Okay, the first thing we need to determine about the fetal heart rate is what is the rate. So just like you put a stethoscope on someone's chest and you count, you're counting what their heart rate is. So we're looking at the monitor at what the tracing says our fetal heart rate is. And we will write down the number. Now remember, this is in 5-beat increments. Now if you remember, a normal fetal heart rate is 110 to 160 beats per minute. So hopefully when we're looking at our fetal heart rate, we are getting a number between 110 and 160. It's 110, 115, 130, 135, okay? When we determine fetal heart rate, it has to be at least 10 minutes of the strip. Okay? So when we look at 10 minutes of the strip, we're just looking at the line going across the paper. We're not looking at anything. Okay, let me go back to the PowerPoint here. When we're looking at the heart rate, we're looking at in this 10 minutes, so say this strip is 10 minutes, we're looking at all these squigglies. We're kind of trying to draw a line between the center of these squigglies. Now you'll have some marks below, you'll have some marks above, but on average, we're looking for where the line would be in the middle of all these squigglies. And in a 10-minute period, because we need 10 minutes to determine a baseline, then we see what that number is. And in this case, it's 150. Okay? So let's go back. So we're looking at that tracing in a 10-minute period. Okay? We need to see at least 2 minutes and in that 10-minute period, okay? So a baseline basically is from 2 to 10 minutes. We want at least 2 minutes of this tracing going across up to 10 minutes, okay? So that's kind of confusing, but you'll see why I pointed out 2 minutes and 10 minutes here in a minute, okay? So basically, in a 10-minute period, we're looking for that line that's going across, and if we were to draw through that squiggly line, draw a line right through the middle, where would that land on that paper, okay? So we want it to be between 110 and 160, okay? If it's below 110, then it's bradycardia. If it's above 160, it's tachycardia, okay? All right, so we've got our fetal heart rate baseline. Now we want to determine variability. Variability is the fluctuations or the variations in that tracing that's going across the paper, okay? So if you can see all these squiggly up and downs, okay, that's what variability looks like on a piece of paper. It's all these up and downs, okay? Now, how big are those up and downs is what we need to determine. How big is the amplitudes? Now remember, on our fetal heart rate tracing, between this line and this line, that's 10 beats. So that's how we can determine how big those amplitudes are, how big those variations are, is if those amplitudes are taking up that entire block, then the beat to beat ratio is 10 beats, okay? If it's only going half of the block, it's only 5 beats, okay? And so once we've determined, is that 5 beats or 10 beats, then we want to say what it is, the average of those variations in that 10-minute period. So we don't want to just look at this little section right here and say, oh yeah, this is what my baby's variability is. It's based on this little section right here. Okay, remember, from the dark line to the dark line is 1 minute, so this is 10 seconds. So 30 seconds, I'm going to determine what my baseline is? No, I want to know for this 10 minutes what the average of all these fluctuations are. Okay? Now, go back here. So we have different levels of this variability. We have absent variability where it's undetectable. Like basically I drew a straight line across the paper. There's no variations or fluctuations. It's a flat line, kind of like asystole. Okay? That's absent. If the beat-to-beat variation or the fluctuations is less than 5 beats, okay, so less than half of the block up and down, less than half of that block, then we're saying it's minimal. If the fluctuations are 6 to 25 beats, so more than half of the block, but each block is 10 beats from one block to the other, so here's 10 beats, here's 20 beats, and then half of the other. So that's large variations, right? Okay, large fluctuations. We're saying that our variability is moderate. And then if it's greater than 25 beats, we're saying our variability is marked. Okay, why is that important? Variability tells us the oxygenation status of our baby. So if our baby has a normal baseline, a normal heart rate, 110 to 160, but the variability is telling us our baby is poorly oxygenated, we're going to do something for our baby. It doesn't matter that it's a normal heart rate. If our oxygenation is bad, we need to do something, okay? You can have a normal heart rate with bad oxygenation. You have to do something, okay? So which one is bad oxygenation? Variability tells us the oxygenation status of our baby. And if our variability is undetectable or absent, then we're saying that our baby has bad oxygenation. Undetectable, bad oxygenation. So we're going to do something for our baby. If our baby's variability is minimal, less than 5 beats, we're going to say that our baby is minimally oxygenated. We're probably going to do something for our baby, okay? But I said probably, because our baby may be sleeping in utero and not having a lot of fluctuations, and that's okay, that's normal, but those sleep cycles don't last very long. So in 10 minutes our baby may still be sleeping, but in the 2 hours we've taken care of our baby, you know, our baby should have had a wake cycle, okay? And if we're still having minimal variability beyond 40 minutes, actually a sleep cycle is 40 minutes long. If we're still having minimal variability, then maybe our baby isn't just sleeping, and maybe our baby is having an oxygenation problem, okay? If we have moderate variability, we're going to go yeehaw, because that means our baby is oxygenated and we're super happy. And as a matter of fact, this baby right here has moderate variability, so we're really happy with this baby, okay? If our baby has marked variability, so more than 25 beat variations in this heart rate or in this variability, then we have marked variability, and that's not good. That's our baby working his butt off to be oxygenated. That baby is trying to be oxygenated, okay? That baby is working hard to be oxygenated, and that baby is going to end up getting tired, okay? So with absent variability, minimal variability, and marked variability, we need to help our baby. All right? So we've determined our baby's baseline heart rate. We've determined our baby's oxygenation status by defining or labeling our variability. Now we're going to go up here and we're going to ask ourselves, is our baby having accelerations in the heart rate? Okay, so when you run up a set of stairs, you have an increased heart rate. That's normal, and that's positive. That's your body's way of supplying oxygen in a high-stressed situation or in activity. So that's good. That's something that you want to happen. And we want to see accelerations in our baby's heart rate. Sick babies don't have accelerations, okay? Accelerations are a positive sign that we see in our heart rate. Now, accelerations have to be 15 beats above the baseline and last for 15 seconds, okay? 15 beats above the baseline and last for at least 15 seconds, all right? If it's a preterm baby, then we say that the beats can be 10 beats above the baseline for 10 seconds. Okay, so let's look at that. Let's look and accelerate. This isn't a good picture. So, okay, so just remember that, and we're going to go look at some accelerations. We want our acceleration to be 15 beats above the baseline and last at least 15 seconds. Okay? Now, remember when I said when we were looking at the fetal heart rate baseline, 2 minutes to 10 minutes, okay? So if we have an acceleration that's lasting longer than 2 minutes, we have what we call a prolonged acceleration. Oh no, I didn't say it there. A prolonged acceleration, okay? So that's okay. We can have a prolonged acceleration. But if that acceleration now lasts more than 10 minutes, then we have a baseline change, okay? So that's why we need to see a minimum of 10 minutes to determine our baseline. So if it's more than 10 minutes, it's a baseline change. If it's less than 10 minutes but more than 2 minutes, it's a prolonged acceleration, and that's okay. And if we have a baseline change, that's okay, as long as the baseline change is still in normal limits. Okay? All right. Now, so we've determined our heart rate, we've determined our variability, we've determined if we have accelerations. Now we need to decide if we have any decelerations. Decelerations are a drop in our heart rate, okay? There's 4 different kinds of decelerations. One of them is an okay deceleration. We don't do anything about it. The other 3 we want to do something about, okay? Now, on the screen you'll see late decelerations there. Skip that for a second. Let's talk about early decelerations, because this is the one that's okay. This is the one that you're not going to get all freaked out about. An early deceleration is a gradual decrease in the heart rate from baseline, okay? So the heart rate is going to gradually descend, okay? And it's going to take 30 seconds or more for it to go from baseline to its lowest point. So the heart rate will drop and then it'll return back to baseline. Okay? So when it drops, when it gets to the lowest point and starts to go back up to the baseline, that's greater than 30 seconds. Okay? So the whole deceleration from the time it leaves the baseline till the time it gets back to the baseline might be 60 seconds long. But it takes greater than 30 seconds for it to leave the baseline and get to its lowest point. Greater than 30 seconds. And remember, we can count how many 30 seconds are because these small blocks are 10 seconds. So as it's declining, it's taking more than 30 seconds to get to its lowest point, and then it's going to turn around and go back up to baseline. Okay? Now, not only does an early deceleration take greater than 30 seconds to leave the baseline and get to its lowest point, it's happening at the same time as the contraction. Okay? So it basically looks like an upside down contraction. So if you were to take this and completely flip it, that's what it would look like on the baseline. Okay? It would start at the same time the contraction starts. It would get to its lowest point the same time the contraction gets to its highest point. And it would end at the same time the contraction ended. That's called an early deceleration. Okay? What does an early deceleration tell us? What's going on with the baby? It tells us that it's head compression. An early deceleration means head compression. The head is dropping down into the birth canal and it's getting compressed. That's what happens when babies start to come out. Okay? So yay, 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 baby's almost coming out. Okay? So that's okay. Early deceleration. All right? Now, a late deceleration. Late decelerations are bad, 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 bad juju. Late decelerations tell us that there is a uteroplacental insufficiency. What's that mean? That means that there's poor blood flow to the placenta, and or there's poor gas exchange from the maternal side to the baby side. Therefore, the baby isn't getting good oxygen. Okay? These are bad, and these look different on the monitor than the early decelerations. They're the same as the early deceleration in that by the time it leaves the baseline till it gets to its lowest point is greater than 30 seconds. That's exactly the same as the early deceleration. Okay? The difference is the late deceleration starts late in relation to the contraction. So the contraction already starts. It already rises to its highest, most intense part up here at its peak, and that's when the deceleration, late deceleration starts. Okay? And then it's going down, the late deceleration, the contraction is ending, and then after the contraction ends, then the late deceleration returns to the baseline. So it's late in relation to the contraction. Okay? That's bad. That's uteroplacental insufficiency, and you want to help this baby. Okay? Now, variable decels are completely different than either the early or the late, in that when a variable decel leaves the baseline and gets to its lowest point, look at this. It's less than 30 seconds. We call that abrupt. Okay? It happens very fast. Okay? What that is telling us is that there is a cord compression. A variable deceleration tells you there's cord compression. Okay? So just like I put a blood pressure cuff on your arm and I pump up that blood pressure cuff, if I was to palpate your pulse in your wrist would decrease, right? And then when I release the blood pressure cuff, it allows circulation back through and your pulse resumes. Okay? It's the same thing with a variable deceleration. Something is compressing that cord. So she has a contraction. The cord gets compressed between the uterine wall and, say, the baby's shoulder or the baby's leg or the baby's knee or something. The cord is getting compressed during a contraction. Okay? Now, we will see variable decels even when a person is not contracting. Because why? Why would the cord be compressed when someone's not contracting? Because they have decreased amniotic fluid. There's no fluid in there cushioning the cord. Or her water broke, and so all the fluid has rushed out and nothing is in there cushioning the cord. Okay? But anyways, for our purposes, variable decelerations with the contraction, they're an abrupt drop from baseline. Okay? They mean cord compression. The last deceleration we're going to talk about is prolonged deceleration. It is similar to the prolonged acceleration in that it lasts 2 minutes long, but less than 10 minutes. Okay? So it could last for 3 minutes, 4 minutes, 6 minutes. It's less than 10 minutes. It's a prolonged decel. If it lasts longer than 10 minutes, what is it? It's a baseline change. Okay? Now, if it's lower than 110 beats, then it's bradycardia, right? Okay, right. So, let's take a look at what this looks like on a fetal heart rate tracing. We will come back to the classifications in a minute, but I want to show you what these look like on a tracing. Okay? In a minute, as soon as I get there. Let's go faster. Don't get dizzy. Here we go. Okay. Okay. Don't look at anything else but the fetal heart rate. Don't look at these big drops in the heart rate. Look at, and I know this is hard to see because it's small. Look at this baseline. Okay? Way up here. You can see 180, can't you? And this baseline is way up here at 180, 185. What is that? It's tachycardia. Okay? That's not good. Look at this one. Look at this line all the way across here. You can't see the number because the line is running right through it, but that's 90. We can count it. So here's 60, 10 beats, 70, 10 beats, 80, right here, 90. Okay, what is that? That's bradycardia. Okay, I know the answers are there, but you know that. Okay. All right, we didn't show you a normal baseline. It's in here. It's in the PowerPoint. This is a normal baseline. It's running at 150, right? We're drawing our line through here. That's a normal baseline, 150. Okay? Now the next thing after we determine our baby's heart rate is we're looking at that variability. Remember I said variability tells us about oxygenation of our baby, and there's 4 levels, the first level being absent. This isn't a great picture because you do have a little bit of fluctuation right here in that line, but over this entire 10-minute strip, so you're not looking at one area and saying, oh, I have minimal variability. You're looking at this entire 10-minute strip, okay? And although some people might argue still that this is minimal, this is absent variability straight across, okay? Your baby is very poorly oxygenated, and I'd rather err on the side of caution and treat my baby than to not treat my baby, okay? Here is a picture of minimal variability. So we do have some fluctuations in our heart rate, but minimal, less than 5, so less than half of the block, okay? Minimal variability. Our baby is minimally oxygenated. But look at this craziness. Look at all these up and downs. Wow, that's moderate. That's more than 5, less than 25. You can count those blocks, okay? So we are less than 25, all right? So that's moderate variability. Our baby is oxygenated. Now here's marked variability all the way across that paper. Now look at this little section here. That's not marked. That's not greater than 25 beats, but we're not looking at one little section. We're looking at our average across a 10-minute strip. And those are definitely bigger than 25 beats. That's marked variability. Our baby is telling us, hey, look, I'm working really hard to try to get oxygen and I'm going to get tired. You need to help me, okay? Now, We've determined baseline, we've determined variability. Now we're going to ask if we have any accelerations in our heart rate. Remember, accelerations are rises in our heartbeat greater than 15 beats above the baseline. So here's our baseline, kind of 145-ish, right in the middle. And that's kind of the way it is all the way across the strip. If I was to draw a line through the middle, all the way across the strip, it's 145, okay, ish. Accelerations are 15 beats above the baseline for 15 seconds. That makes an acceleration. So, so these little things, like this one right here, that's not an acceleration because it's not 15 beats above the baseline and it doesn't last 15 seconds. So these big whoppy dealies, those are accelerations. Those are good. We like those. Yay. Okay? Now here's prolonged accelerations. So this is where you have accelerations that last longer than 2 minutes. And even though we have these little breaks where it drops down a little bit, basically this acceleration, it starts right here and it lasts 1 minute, 2 minutes, almost 3 minutes. Over here, this one lasts 1 minute, okay, and it comes down. But look, if we started here even, 1 minute, 2 minutes, 3 minutes, almost 4 minutes, so that's prolonged, okay? If it lasted longer than 10 minutes, it would be what? A baseline change, okay? This isn't a prolonged acceleration. Now we're going to look at earlies, and I'm just going to apologize for these tracings. They're not very evident, okay? But trust me, this is what they are. And this is what your baby's going to look like because your babies didn't read the textbook. So babies are going to do what they do, and it's best, and we do our best to interpret to the best of our ability what that baby is doing. So these are examples of, not this one, okay, but these other ones are examples of early decelerations, and I'm telling you, I'm sorry, this one isn't a great picture of that. So here's your baseline coming along here at 150, and then right about here, you see my cursor, it starts to drop. It comes down to here, and reluctantly it comes back up to baseline, okay? So this basically mirrors the contraction. It starts at the same time, it ends at the same time. Now the only argument you have is how long is it taking from leaving the baseline to getting to its lowest point. So, you know, this is right at 30 seconds, maybe even a little less, but, you know, it acts like a duck, it walks like a duck, it quacks like a duck, it must be a duck. So it pretty much follows the rule for an early deceleration. This one's even harder because, look, from the time it leaves the baseline to the time it returns to the baseline, it's only 10, 20, 30, 40 seconds. So, sorry, it doesn't quite fit the rule of the gradual descent, but it starts the same, it ends the same, it looks like a duck, so it's a duck, okay? Same with this one, little better animation here. Same with this one, a little better animation here. This one does not follow the rule at all. We're not going to talk about that because that is actually not an early deceleration. But anyways, so if your patient says to you, or if you put your patient on the monitor in the clinic and you see this right here, early decelerations, and she says, oh my God, deceleration, is that bad? You say, no, those are earlies. That means your baby is wedged way down the birth canal and the head is compressed and you're close to delivery. Let's go to the hospital right now, okay? Okay. Now, and again, these aren't great illustrations, but this is a late deceleration picture. So we have our two contractions here, and we have our baseline running across here. It looks like our baseline is probably 135. Okay. Our variability, I'm going to call this variability probably minimal. But what we're looking at is the deceleration. So here the contraction starts over here, right here. Okay. Right? Here's a contraction. So we draw a line up. No decel, no decel, no decel. No. Here's our decel. Look, it starts at the peak of the contraction. So it starts late. Here our contraction ended. Let's drive up. Straight up. We're still in a deceleration. Still, 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 and here we are at baseline. So that's late. Same here. Our contraction starts here. Let's drive up. Okay, no decel, no decel, no decel, no decel. Oh, here we have the decel starting. Okay, and here we have the peak of the contraction. So that's late. All right, that's a late decel. That means uteroplacental insufficiency. Please help your baby. All right. Now let's talk about variable decelerations. Remember I said variable decelerations are cord compression? Remember cord compression was it dropped less than 30 seconds? So they look kind of abrupt. Look how these kind of look different. They're deeper and they're more abrupt. Okay? Now, like the other ones, they don't always follow the rule hard and fast. So let's count this. 10, 20, 30. So this is right at 30, maybe a little more seconds that it left the baseline. But look, it looks abrupt, it looks pointy, it looks abrupt going back. Look at this one, abrupt, abrupt, pointy, abrupt, abrupt, pointy. These are variable decels. These are core compression. So they're not late. So like if you're questioning whether this is a late, it's not. Because it starts the same time the contraction does, it ends the same time the contraction does. Its peak and peak are the same. Its nadir and its peak are the same. So this is not a late. So you might want to argue early. Well, fine, argue early. I don't care. But look at this one. This one is a variable. But look, it's happening late. So why am I not calling it a late? So it's not that this is subjective. This is, you have to use your critical thinking. Does it look like a duck? Does it talk like a duck? Does it quack like a duck? Is it a duck? Okay? So what does this look like? It looks abrupt. It looks variable. Okay? So that's why reading fetal heart strips can sometimes be confusing. And I can come in here and say this is a variable, and the nurse behind me can come in and say, no, that's an early. Or I can say this is a variable, and the nurse behind me can say, no, that's a late. Okay, so yeah, I'm sorry this is not hard and fast. Babies don't read the book, but this looks like a variable to me. It looks abrupt. It looks deep and abrupt. Okay, my cord is getting compressed. Okay, am I going to treat this? Yes. If it was a late, am I going to treat this? Yes. So I'm not going to argue over is it an apple or is it an orange. I'm still going to eat it. Okay, all right. Now, so these are variable decels. These tell us cord compression. Okay, we're going to treat these. Now, just like we had prolonged accelerations, we can have prolonged decelerations. They're decelerations that occur. They last for greater than 2 minutes, but they don't last longer than 10. Oh my gosh, 10. Because if they lasted longer than 10, what would they be? They would be a baseline change. Okay, now, we're going to treat these. Now, I've been telling you, treat your baby, help your baby, treat your baby, help your baby. How do you do that? Well, you do that by repositioning mom. Maybe if you reposition mom, you're going to get better blood flow to the placenta. You're going to get better oxygen exchange, and you're going to give your baby more oxygen. If you change your mom's position, you might take pressure off the cord. So position change is the first thing that you're going to do. The other thing that you're going to do is you're going to give her an IV fluid bolus, okay? Increase her blood flow. Increase blood flowing to the placenta, all right? You're going to give her oxygen. You're going to increase her oxygen saturation so that she has more oxygen to exchange in the placenta, okay? And then if you have Pitocin running, you're going to turn that stuff off, okay? Because what did I say? If you have Pitocin running, you're going to turn that Pitocin off because we need to start taking some stress off the uterus, off the contractions, off the baby, turn the Pitocin off, okay? Now, you've done all those things and you're still having these bad heart rates. Now you call your doctor and you say, hey, I need you to come in. I have this is going on with my baby. I've done all these things. I have not improved the baby's oxygenation status. I need you to come in, okay? And so he'll come in. All right, now let's jump back up here and talk about the categorization real quick. Let me look at my time. Where's my time? Oh well, I'm over time and I'm sorry, but let me do this, okay? Because you're at home relaxing. let me tell you about the classifications, okay? So there's the three classifications, and A1 wants us to categorize our fetal heart rate, okay? So depending on what we do, what we determine when we assess, we'll put all this stuff in our documentation, and then we'll say, okay, my fetal heart rate tracing is a category 1, 2, or 3. Now, let's talk about 1. That's a normal tracing, okay? So you've got to have two things when you have normal tracing. You've got to have a normal baseline rate, and you've got to have moderate variability. You've got to have those two, okay? You've got to have those two, okay? You cannot have late or variable decelerations. You can't have one, okay? You can't even have one. You can't have them, late or variable, okay? You can have an early deceleration. Remember I said early deceleration is head compression. That means baby's coming. Okay, we don't do anything to early decelerations. That just tells us that baby's got head compression. Okay, you can have early decelerations. Don't necessarily need to have them, but if they're on your strip, that's okay. You can still categorize this as a category 1. You have to have a normal baseline rate, you have to have moderate variability, and you cannot have late or variable decels. Okay, category 1. Now let's just jump down to category 3. Category 3 is you have absent variability. Remember, absent variability is that straight line across. It's asystole. There's no variability. Your baby is not oxygenated. You have to have absent variability to be in category 3. But you also have to have, okay, you have to have absent variability and either recurrent late decelerations, recurrent variable decelerations, or bradycardia. Okay, so you have to have absent variability and one of these other 3 things that I just said. Recurrent late decelerations, recurrent variable decelerations, or bradycardia. Now listen, recurrent means that you're having these decelerations with at least 50% or more of your contractions. Okay, 50% or more. That's recurrent. Okay, that's important. That's recurrent, okay? So you have absent variability and you have recurrent late decelerations. You have a category 3 fetal heart rate strip. You need to deliver your baby right now, okay? You have absent variability and recurrent variable decelerations. You need to deliver your baby, okay? You've tried everything to fix this. You can't fix it. You need to deliver your baby, okay? You have absent variability and bradycardia. You need to deliver your baby, okay? So you have absent variability in one of these 3, all right? You have a category 3 fetal heart rate, okay? Now look, there's sinusoidal pattern. So that's a whole different pattern. I haven't talked to you about that. I will show you that later. But if you have a sinusoidal pattern, nothing else, okay? Sinusoidal, you deliver your baby right now, okay? And I'll show you that. It's very distinctive. You won't get that confused with anything else. You see that, you know it's wrong. Okay, now category 2, why did I skip that? Because look at all these things that you could have if you had a category 2. Okay, hard to remember sometimes, all right? So the best way to do it is if you're not a category 1 and you're not a category 3, then everything else falls into category 2. It's a endless bucket full of stuff, okay? So to say you're category 2, that means you're saying you're not category 1 and you're not category 3, right? Because there's some specific criteria to be category 1. There's specific criteria to be category 3. If you don't make those specific criterias, then you're a category 2, okay? Category 2 does not mean you have to rush off to the OR. Category 2 means you have a baby that's in trouble. You need to be doing some things to fix it, okay? You may fix it. You may not totally fix it. You may partially fix it. You may not fix it at all. But the physician says, I want to still labor her. Okay? All right. Let's go look and see what those look like. Okay? Hold on. Don't get dizzy. We're almost done. I'm going to be done talking here in 5 minutes. Okay? So, hang on. Okay. Hang on. Here we go. Oh, this shows us uterine contractions, okay? So we counted our uterine contractions before, we counted our duration. This is normal uterine activity as opposed to non-normal, too many contractions, okay? Too many contractions. That's called tachysystole. How many is too many contractions? Well, A normal contraction pattern we want to see in labor, at least we want to see contractions every 2 minutes, every 2 to 3 minutes, okay? So every 2 minutes. So if you have contractions every 2 minutes, well then in 10 minutes you have 5 contractions. I don't want any more than that. I don't want more than 5 contractions in 10 minutes. I don't want my contractions any closer than 2 minutes. If I do, they have tachysystole. If I have tachysystole, I could hurt my woman's belly. I can hurt her uterus, okay? I could rupture her uterus, I could cause bleeding, or I could stress my baby out and I could start having bad baby heart rates, okay? We don't want tachysystole, okay? Now, here's category 1. What is category 1? We have a normal baseline, right? And we have moderate variability. We have to have those 2 things, okay? If we have those 2 things and no late or variable decels, then we have a category 1. And this is a category 1. Okay? Let's skip category 2 and go straight to a category 3. Okay? Category 3. Okay? We have to have absent variability to be in a category 3. Okay? But with the absent variability, we have to have recurrent decelerations. Okay, recurrent means greater than 50% of our contractions, and she's having them with every contractions. These are variable, right? Abrupt means variable, means cord compression. We have absent variability, we have recurrent variable decelerations. This is category 3. Now, remember I told you sinusoidal pattern is very distinctive. You won't miss it. You will know it when you see it. You will see it and you know it's bad. This is bad. This is a sinusoidal pattern. Okay? Get her delivered. Okay? Now, we saw category 1. Okay? Variable decels. Now let's look here. Okay? We're gonna go up. Okay? So we have variable decels, but we don't have them with 50% of our contractions. Okay? We have 3 here, and we have 1, 2, 3, 4, 5, 6. Okay, so yeah, you can say 50%. But we don't have minimal variability. That's important. We have to, we don't have absent variability. I'm sorry. We have to have absent variability to be in category 3. Okay, we don't. All right, here is recurrent variable decels. That means we're having them with at least 50% of our contractions, but again, we don't have absent variability, so we can't go into category 3, so this is category 2. All right, look here. We have prolonged decelerations, we have variable decelerations, we have decelerations with every single contraction, but we don't have we don't have absent variability, so we can't be category 3, so we're category 2. Here we have recurrent decelerations, but we have moderate variability. We can't go into category 3. You're getting the drift here, okay? Here, they're calling this absent variability. Someone else may call this minimal, but for lecture's sake, this is absent variability, okay? Absent variability. You have to have absent variability to be a category 3. This is not a category 3. Why? Because I don't have decelerations, recurrent decelerations. I can't be category 3. Okay, so it's category 2. All right. Here's decelerations, but I have marked variability. I can't go in category 3. This is category 2. All right. Here is absent variability. I have to have absent variability to go in category 3. However, I do not have recurrent decelerations. So what? I'm not category 3. This is a category 2. All right? Okay, so you guys get it. All right? So I think I've made it through my lecture. Thank you for letting me go long while you're sitting with your feet up watching TV as well. Okay, guys. So if you have any questions, please call me. Your exam is Sunday, right? Okay, very good.